friends, I am going to talk about avascular necrosis of hip. It is also known as osteonecrosis. Actually, avascular necrosis is a misnomer because it's not only the avascularity which leads to the necrosis of the bone, but it's a multifactorial actually. So, what are the most common risk factors for avascular necrosis of the hip joint? Number one is steroid intake, especially after COVID. We have seen many patients who have been given steroids in high doses. They presented later on with the hip pain, and on MRI they found to have a avascular necrosis. The another most common reason is alcohol intake. So these two things are the most common risk factors for avascular necrosis of hip joint. There are so many other causes as well, like it could be traumatic, then there are some coagulopathies, hyperlipidemia, sickle cell disease, Kazan disease. Those things are the rare causes of avascular necrosis. So coming to the symptoms, the patient may present with not only hip pain, but they sometimes present with the knee pain and sometimes with the back pain. And we have seen patients have been misdiagnosed because they will not clearly say that the pain is coming from the hip. So we have to be very meticulous. We should have a high index of suspicion to diagnose the AVN of the hip, and we should clinically properly, we have to examine them to rule out the AVN. And in all the cases, in early cases, we have to do the MRI because MRI is very sensitive test to detect the AVN in early stage. If we only rely on X-ray, there are high chances that we may miss the AVN in early stages. So whenever you have any doubt, take proper history, do clinical examination and do the MRI to rule out the early AVN. So coming to the staging, there are various stages of AVN and there are various staging methods. Ficat and Arlet is the most commonly used AVN staging system, which is based on the radiological parameters. Stage 1 is there is no obvious changes on the X-ray. Stage 2 is some sclerotic changes. Stage 3 is crescent sign, which is a subchondral fracture, and stage 4 is the advanced collapse of the femoral head. So why we are worried about AVN? What will happen? Unfortunately, it affects the young people, mostly the 20s to 40 age group patients are affected, and it is a very progressive kind of disease. So if you don't treat them, there are chances that 70 to 80% of the patients will land up in 3 to 4 years for total hip replacement. So we have to diagnose them early and treat them. So what are the treatment options? First option is the medical management, which includes bisphosphonates, physical therapy, and strict non-weight bearing exercises. Those things can be done. And it has been seen that if the area of involvement is less than 30%, then there are chances that we may get away with the medical management. But most of the time we have seen that the disease progresses with the medical management only. So coming to the surgical options, we have a hip preservation option and the hip replacement. Obviously no one would like to go for hip replacement. So if we diagnose them early and treat them early, there are chances that we may prevent the further collapse, and eventually patient might not require hip replacement. So what is core decompression? Suppose this is your hip joint and this is the area of involvement of the avascular necrosis. This is the dead cells in the subchondral region. So what we have to do, we have to make a drill hole like this. You can see there is a tunnel we have to make, and we have to decompress it. So how does it help? Actually, it decreases the intraosseous pressure, decreases the pain, and increases the neoangiogenesis, neoosteogenesis. So that is one thing by which, and it is a time-tested procedure, but then the success chances is very low. Almost we can say literature says 50% patients may recover. But then coming to the next option, what it has been seen that many surgeons have started putting the bone graft. They have taken the bone graft from the iliac crest or from the fibula, and they, after core decompression, they have put the bone graft. So but the challenge with this procedure is that there is two-stage procedure and there is a morbidity associated from the donor side. So the patients don't like this procedure much. And coming to the next option, it is called as BMAC, or bone marrow aspirate centrifuge. So this is another latest, you can say, treatment option available. In that, what the surgeon does, he does the core decompression followed by aspiration of the bone marrow from the anterior superior iliac spine, and they centrifuge it in a machine, and then they extract the certain amount of cells and they inject it in the cavity. Like once you have done this core decompression, you can inject the BMAC aspirate into the cavity. But the challenge with this procedure is that the amount of pluripotent cells, the stem cells, are very low, and it has been seen it is almost 10,000 only. So those cells, the number of cells are not sufficient enough to give a good quality of bone. And another challenge is the bone marrow aspirate is injected in a liquid form, so there are chances of spillover. So then comes the next level of treatment, we call it regrow or osgrow. So what is osgrow? It is a two-stage procedure. In first stage, we take the bone marrow sample or bone marrow aspirate. Around 15 cc of bone marrow is aspirated from the posterior iliac superior spine. It is done under sedation or maybe some small anesthesia, local anesthesia. And after almost a month, the collected sample is sent to the lab. There are specific vials available in which it is transported to the lab, central lab, and there it is grown. There is a specific type of cells, we call it osteoblast. Osteoblasts are the only bone forming cells in the body. So they are cultured and they are nourished, and to the number of 50 million cells, almost 50 million cells are transplanted in a second stage after almost a month. Then comes the main procedure, wherein what we do, we have to, again same procedure, we have to do the core decompression like this, and we have to remove the dead and necrotic part. So we have different curettage available through which we will remove as much as possible the necrotic tissue, and we will inject through a long needle the cultured osteoblast. The advantage with this procedure is the number of cells, the mesenchymal cells, are 48 to 50 million cells, which are very high number, very good quality of number. And another thing is they are providing as a jelly form. The method of delivery is in a jelly form, so that it doesn't spill over. So we can be assured that it is delivered properly in that area, the desired area. So that ways it is giving good result, and we have done number of cases and we are seeing a lot of improvement in the patients. But then if you ask me what are the ideal patients, so stage 2 patients only and stage 3A early, less than 2 millimeter collapse, those are the ideal patients who can be benefited with this technique. Once the head get aspherical or start collapsing, it's difficult to regenerate it. So we have to catch them early. If you diagnose them early and you treat them, almost 100% recovery is possible. And then there are few more technical tips we will discuss during the operative procedure.